Okay, welcome everyone. Welcome to our Thursday conference, and it's good to see a few of the bioinformatics folks here. We have a somewhat clinically oriented talk today, but that's fine. I'm pleased to introduce someone who many years ago sat in this room as a student. Dr. Jay Eisenberg is actually an alumnus of our program. He was a pediatric pulmonologist. I guess I can violate HIPAA, but my daughter actually saw him as a patient when she was. It was actually before HIPAA, so I guess maybe HIPAA didn't apply. Anyways, he was a pediatric pulmonologist here at OHSU, and like a number of you, got the informatics bug. And made a complete, he did our master's program. In fact, you know he did it a while ago because his degree is actually called medical informatics, back before we changed it to biomedical informatics. And anyways, he then had a very successful career. He worked for many years for Cerner. Actually, it might be interesting to hear what he thinks about what's happening with Cerner now. Maybe he'll talk about that, all the new contracts and so forth, the new big contracts that Cerner has. And then I think he got tired of traveling, so he came back, took a job with Southwest Washington Medical Center.
I'll go through a little bit of that too.
Yeah, okay, I'll let him tell the whole story. He's also been a member of our affiliate faculty, so he has interacted with the program in many ways. He's a physician by training, went to medical school at Baylor College of Medicine, I guess, and trained in pediatrics and then pulmonary medicine. So I will let him fill in all the details.
Thank you, Bill. Hello. Just a question: who's more on the applied clinical side, and who's more on the scientific side? Even though research, yeah, just kind of curious. Who's clinical? Okay, about half and half. Okay, well, those of you who aren't, I'm happy to have you here. And actually, I felt a bit intimidated coming here and talking about this, because I'm going to talk about a few things that I learned in the program, but I am not going to tell you other than how important they are. I mean, you have people who are really experts in some of these areas. So my goal is just to tell you about kind of how I ended up where I am and what physician or clinical informaticists or CMIOs do. And there's a lot of different titles now. There's CMIO, and there's Chief Health Information Officer and Chief Health Informatics Officer. And wherever you work and wherever you are, whatever happens today won't be the same tomorrow. And Dan can attest to that as we go through changes in our governance, which I'm going to talk about as well. So, and I do have an MMI, which can't get anymore. When I started the program, that wasn't even available. It was only an MS in 1997. So I wasn't actually sure what I was going to do, but ended up with the MMI. So I'm going to talk about the items in the box a little bit. I'm not going to talk about the items that are at the bottom. Not that they're not important, but I just didn't feel like there was enough time, and wanted to talk about a couple of those other things. But I'm going to be staying around, and we can certainly go ahead and freeform this as well. People, if any of you have questions about some of those other areas, I'm happy to talk about it. And between Dan and I, you've got about, I don't know, 25, 40 years of combined experience doing this. So 35, 40, yeah. So I had to write some questions for this, and these objectives sort of point to those. They're not hard. They're just, that was what I had to do. So I want to talk a little bit about the usual competencies and requirements, reasons to have governance in a healthcare organization, or really any other organization. Know the organizational levels that are important. There's one slide on organizational behavior, because I could not do Joan Ash any justice in that area. And I'll talk about my experience in that class and why I think it's so important. And then finally, just a little bit on change management and adoption. So Bill went through some of this. So I practiced Pete's pulmonary here, and then I was involved in helping with decision making about some information systems at the time. This was over early 90s. So standalone, this or that, results review system, which doesn't exist much anymore as that, that kind of thing. I got interested. I actually went to Bill. Came to Bill and said, so I'm interested, what do I do? And he goes, well, take my class. And I took it, and I go, I liked it, what do I do? And he goes, take another class. And I did. I go, now what? And he goes, you have to apply the program. So I did, and just sort of pecked away at it. So I was here until 2000, and I left. I had an opportunity to do something else, which ended up being 7.5 years with Cerner Corporation, so a big EHR company. That was a cultural change for me. It was quite a different kind of culture. And then I had an opportunity to become the CMIO over at what was called Southwest Washington Medical Center in Vancouver. And I had always lived here. In fact, my house used to be, until I sold it in June, was up the hill, down Fairmont a mile, and down about 2 blocks. So was close by. And so I stopped weekly travel and started commuting, which I'd never done much in Portland. And that became interesting, as you know. And then as part of Southwest Washington Medical Center, they started talking to PeaceHealth about an affiliation. And that happened. So they're nonprofits. They affiliate, they don't acquire, that was the term. So we became part of PeaceHealth. And I stayed at Southwest until 2003, at which time I took this position, which didn't really exist, largely to work on the implementation of the system-wide electronic health record, which is EPIC. Our ambulatory clinics had already started that, but they needed a CMIO for that. So I was kind of in the right place at the right time, and the opportunity was there. And it was a position that was posted, and I applied, and there I was. So PeaceHealth, I'll show you another slide, is kind of a medium-sized health system. There are really big health systems around, and then there are smaller. So there are, I'll show you a map, but there's about 16,000 employees. So UPMC had what? About 60,000. So bigger system. And then, they're big and small and medium. There are 10 hospitals, and I'll show you how they're spread out because it's kind of important. 5 are critical access hospitals. Critical access hospitals, if you don't know, are subsidized hospitals that can have a maximum of 25 beds that serve rural communities that need access. And there's an employed medical group, about 1,000 providers. So there are 3 networks of care that are really geographically quite distinct, which makes covering them a challenge. So my colleague at Legacy, Amy Chalmanton, who's the CMIO, can get in her car if she needs to meet one group of people at one hospital and then go to the next. I can't do that. So the Northwest, I'll start at the top. Northwest Network includes those 4 facilities. Ketchikan, if you haven't been up there, it's kind of the first town in Alaska. It's got about 8,000, 9,000 people, and it sits on a big island up there, and only way to get there is to take a boat, take a plane, or swim. So I take a plane. It's about an hour and a half from Seattle. It's got a critical access hospital, a very busy, high acuity critical access hospital, because you can't put someone in an ambulance and take them down the road to the big medical center. Okay. There are 3 facilities here. One is a large hospital in Bellingham. There's 2 smaller hospitals, one in Friday Harbor, which is in the San Juan Islands, and one down in Cedro-Woolley, which is 25 miles south. A hospital in Friday Harbor, it's a medical center, very low acuity. The average inpatient daily census is 1. They don't really keep very ill patients. So anyone who's mildly ill is flown or taken by boat over to one of the other hospitals or flown to Seattle. 2 hospitals, what we call the Columbia Network, one in Longview and one over in Vancouver. They're both larger hospitals. And then there's 4 down in Oregon, Eugene, Springfield, Cottage Grove, and Florence. So that just gives you a sense of the spread of it. There are no 2 health systems in this country that are alike. And so this is just the way PeaceHealth is set up. So first thing I want to talk about is the competencies. And this may be incomplete. But I went through and I kind of looked at the competencies that AMA had listed. This is paraphrased from AMA. And then I looked at the clinical informatics board competencies and try to put them in sort of different boxes. And there, things like documentation and CPOE aren't competencies, but they take a lot of understanding and effort in a big healthcare system. I just wanted to call those out. But change management, adoption, strategy, governance, budgeting and resources, program, project management, all of the things on here I am involved with, or I lead or co-lead, or I go to meetings and discussions and learn, because I'm not an expert in many of these areas. Other CMIOs that I've met over the years have areas of expertise that are different. So I have colleagues around the country who are really much more, are better versed about reporting and analytics. They can write SQL and go in and do that. I can't quite do that, but I kind of know what needs to be done, and I can sit with a reporting analyst and quickly define what I need. Although the boards that I took had one question. It had 4 SQL queries. We had to say which one was correct. So you do have to understand the logic and the approach, but I'm not on that. I'm not that deep into that. A lot of the billing and revenue cycle parts of things, I'm also not, I'm not quite an expert in. But our revenue cycle team is involved with almost every discussion that we have, because there isn't anything, there's almost nothing you do in electronic health record or changing a workflow or adding content that won't affect revenue. And they're very sensitive to that. So things that don't seem to affect revenue do. And I learn new things every day. So that's an area. And then these other areas are, as you can see, I put this one here because this normally is not a core competency, at least of many chief medical information officers or equivalent. But I have many colleagues who know this stuff. They came up on more of a technical side and are really quite good. I have a couple of friends who were CMIOs and are now CIOs, who are physicians, so they obviously have much more expertise in this area. But they don't really manage, they manage the budget and the resources, and they depend on really smart people to help with that. No one's ever going to come to me and say, how many servers do you want me to order? No. They're going to say, I don't know. I know what those are. So that's sort of the area of competency, and those of you in clinical areas will probably have a couple of areas that you start with as expertise, and depending on where your career goes, you tend to learn things. So when I left my clinical practice, I haven't seen a patient in 17 years, which was a big cultural change. I just renewed my license. I still actually have one in Oregon, but I don't see patients. I started working with groups of providers and nurses in areas that I had no knowledge about. I didn't know an anesthesiologist workflow, or I didn't know what an ED physician provider did with a patient with X, Y, and Z. I sort of did, because I used to receive those, but I ended up learning the gory details of many of those workflows and their needs, both in the clinical areas and in the non-clinical areas. So lab and pharmacy, and a lot of those areas you just learn. And you know, over the years, it's become. I mean, I found that it's positive. It's been a positive growth area for me. Don't have, you know, my clinical expertise in the area that I used to have, but I can pretty much go to a meeting at any hospital with any group of providers or nurses and talk the talk and understand what they're doing, at least enough to be competent and not be considered an outsider. So, and stop you. Any questions, I'm happy to stop. This is taken from some job descriptions that I looked at. So instead of the competencies, these are sort of more requirements and qualifications I just wanted you to kind of see. And I try to group them in some logical areas. The top one is kind of a key one, lead, planning and implementation, but all the items about workflow and knowledge of informatics trends and engaging wide areas of providers, and at PeaceHealth we call people caregivers. Understand the way people are and how they're thinking, and understand you're going to go into meetings that are going to be hostile, or that you're going to have to deliver information that the audience isn't going to want to hear, but there are ways to do that by acknowledging it and saying, how can we or I work with you all on what we have to do. So if there's a new regulation and providers or nurses have to do something they don't want to do, but they have to do it, you have to figure out a way to get that done. So that's just an example there. Privacy, security, HIPAA, personal health information, population health, all of these areas are pretty common in a job description and qualifications. And then these are qualifications. So, and this is very narrow. So for a chief medical information officer, chief health information officer, or a physician informaticist. Now, this could be a nurse informaticist too. There is a degree requirement. There's experience, and it kind of depends on the position and the health and the employer, if you will. So for my position, which I'm retiring from in July, I think it says 5 to 10 years is what we're asking. So I get a phone call from someone who's got 4.5 years, and they're worried, should I apply? And those are the kind of things that are negotiable, but you got to have, depending on where you want to end up going, you got to have some experience. And even sort of an entry position, like a full-time physician informaticist somewhere, your experience, you've got practice experience and you're going to have informatics experience, that's fine. And then that's how I think both Dan and I got experience. It was on the job. You just kind of learn that. And then board certification in a primary specialty for some organizations is important, so pediatrics, internal medicine, something else. And then right now, most of the descriptions are preferred for clinical informatics, so those of you who are going there, no, you have to have this in order to be eligible for this, right, Bill? So, that's sort of the qualifications and descriptions. Any questions about that? Okay. So I'm going to talk a little bit about governance. We've only spent 4 hours already today on governance. Yes, we've been on a few calls. So simply stated, in my mind, governance is the ability, provides you the ability to formally say no. So I joke, and I say I have this little string here. And if you pull the string, no. No. So, but no in a nice way. No in a way that lets an idea be discussed and vetted and evaluated. And if it's not the right idea, it doesn't go anywhere. I'll talk a little bit more about that. So the purpose is to have some consistency and confidence so people in your organization know where to go and what to do and who to ask. So right now, when we went up with Epic in our hospitals, which we did geographically, and I'll show you a little timeline, there was thousands of new decisions that needed to be made because we were pulling the rug out from everyone's workflow using a couple of different EMRs in many different ways at the hospitals, and we put in, a system where here are a group of decisions. Here's the people we need at the table. Please come. If you're not there, the decision will be made without you. And that happens a lot, and people come back and say, I wasn't there. And the answer is that's correct, but you were invited. Sometimes that's what happens. So you need a strategy, a clinical governance strategy, a data governance strategy, which is slightly different, and then an IT strategy, which more is your technology and your infrastructure, and some of that. Now, a lot of these overlap, but that's sort of where you go. So you may not be able to see this, but you want to go from chaos to some sort of structure that your constituents, your stakeholders know is there and know what to do and know how to get something in the queue to be discussed. And it's really important, and it's really hard. It's a big cultural change. So we'll talk about that a little bit, organizational behavior. So you really want your governance to be democratic. You don't want it to be tribal, and you don't want it to be authoritarian. I pulled this out of a little article I saw. So democratic, and this is referenced, I found it here. Democratic means that don't govern, try not to govern what doesn't need governance. There's some things that need to be left alone. And then there's other things that need governance. And so, and I'll talk about that. I think that's on the next slide. But you need to figure out what do you spend a lot of time on and effort, and what don't you spend a lot of time on and effort. And and governance, I mean, here, a lot of governance that's outside of this area, there's facilities governance. You need facility work done, and there's this much money, and there's this much time. So what gets done first, second, third, or fourth, and what doesn't get done? It's kind of the same kind of thing. The quality has to do with the validity and the timeliness and the completeness of what is being governed. So you want things to get into a queue and be addressed in a timely manner, and the results are communicated back. The timeliness is hard, and the communication is really hard, especially in a large organization. So what you want governance to do also is to consider access, which is basic sort of a security tenet. Open access means no security. Total security means no access. You got to have a point at which access to the clinical content or the data is it's accessible, but organizationally it's protected. So you have to have that in place. Literacy means that people are using the information or the data, know what it means, and know how to use it. So you may have reporting tools. We had a call this morning about this. So we have to be able to, we're working with our chief medical officers on a couple of reports, and what we're trying to do is come up with a way that they can access things relatively easy and efficiently. It's going to require some training, just as an example. So content governance, the first thing you need to do is decide on what systems you're going to use to collect what you're trying to govern. I mean, it's as simple as an electronic health record, or is it on a pile of paper? You can't do any of the analysis until that part is taken care of. And then analytics is just basically a prioritization process. You've got a lot of data, and then to me the reporting is there. Okay, so I've got a report, and then the analysis of that frequently. So the reporting tends to be a little more IT, but not always, and the analysis is a little more on the end user stakeholder side, but it's a continuum. And finally, standards. Local standards, I'll give you an example. If you have 3 hospitals and they number their rooms differently and call their floors something differently, and you put in an electronic health record, you got to standardize the naming of the floors in the rooms. It's a local standard. Okay? And it's hard for people who are one place to change, because they know that that room down there is room 14B and we're changing it. Industry standards, you're learning all about ICD-10 loading, DICOM. We'll go into that. So this is kind of a high-level view of the governance that we're working on, and it's just it starts with a request, an idea. It gets created. You have to track these somehow. You have to have a tracking system. So they get tracked. Operational owners discuss it. If they think it's a good idea, if they don't think it's a good idea, it goes in the trash can, if you will. If they do think it's a good idea, we have a review process. We're putting in a review process to make sure that all the stakeholders who need to participate in the decision have and the level of effort. If the review process says, oh, the pharmacists need to take a look at this, it needs to go back for review. So you don't want it to get here and then someone to say, like medication reconciliation is one example, where our nurses can't discharge a patient until that process is complete. So if we change the process for the providers and the pharmacists and the nurses aren't there, you hear about it. So you need to make sure everyone's involved. And then in our right now level of effort, there's actually kind of 2 bifurcation points for level of effort. So I put a bread box there. So I say it's either smaller than a bread box, bigger than a bread box, or a bakery. So what we're trying to do is get any of these small requests to just get done. They don't need to go up. They don't need resources. They don't need money. They just need to get done. Anything that is bigger than probably 10 hours, that's analyst and informaticist work, needs to go into a queue where a group of operational owners and me and my equivalent and peers will look at all of these and prioritize them for funding, or they're really big and they need to go to the executive team. So if it's a project that's 10,000 hours and $1 million, it's going to go up to that group to make a decision. Okay? And you can't always tell when you get started how big things are. Some things seem big and they're not. Some things seem small and they're huge. So, any questions about this? And there's a million different ways to do this, or maybe a million. Anyway, yeah.
Do you have resources allocated for those small projects?
Yes, that's a great question. So, you have a group of resources that and I'll focus on the informaticists and the analysts. Now, in our organization, the analysts are with our IT group, but we work very closely. So that group works this many hours, and part of their time is allocated to address things like what we call break fix, right? Stuff has to be fixed. There's other things, compliance and regulatory things that happen that need to happen. So they have a certain amount of time for that. We have upgrades and maintenance, so much time for that. Then the two other areas are optimization, which is a lot of what this fits into, and strategic areas where the organization has something that needs to be done because of its strategic or part of the strategic plan. So the hard part is getting all that done with that many resources. And if it gets here and it can be resourced, that's fine. If it can't, it needs to go for executive review. And if it needs extra resources and they approve it, they have to fund it. But what doesn't work is constantly going and saying, I need more people to do this, that, and the other thing. It doesn't work well like that. So it's a good question. So one slide. So, and just a little story. So when I took organizational behavior from Joan, I had no idea why that class was part of this curriculum. It was required, right? So I did it. Other than Bill's, it was the best class I took. So anyway, it was, when I got done with it, I realized how important it was and how well it was taught. So all I want to tell you is that the biggest challenge are the people challenges and working with an organization. So Joan said once that, what did she say? Organizational culture is social, what did she call it? Social glue? Organizational glue? I can't remember, it's been a while. And that's stuck, and it's kind of the things that are kind of under the mission and vision, and that your leadership will continually reinforce. But there are distinct organizational behavioral differences from organization to organization. And I really saw that a lot back in my Cerner days when I was working with 3 or 4 at a time, and over the 8 years I probably worked with 25 or 30. There were quite a few differences. So you don't get anything done if you don't understand that the organization has this culture. And the only thing I wanted to mention is, and this is from the organizational behavior literature. So, and when I was reviewing it, the one thing I took away is that these are all important. Research-wise, someone may have more of an interest in one area, but everything here is important. So that's my only comment about organizational behavior. So I want to talk a little bit now about change management and adoption, and how to equip and get your organization prepared for the changes that are coming. And this is a constant, this never goes away, but for something like a large EMR implementation or large projects like that, it's enormous. So we had a group of change management professionals working with us through the 4+ years of our, at least our hospital implementation. And I'll show you a little bit of the tools that we used with them. But in kind of the diagrams follow a couple of the change management models. Someone hears about something and they scratch their head, and then most people want to go hide, and they don't want to hear about it because it's not going to affect them, but it does. And then when they realize that it will, people get nervous, scared, terrified. What you really want to end up with is someone who feels successful at having made the change, and they've adopted the change, and they're using, perhaps it's an electronic health record they're becoming experts, if you will. And then you get to a point where if you say you're going to change, we're taking that away and putting in another one, and they say no, then you know you've been successful, because then they've made that change. There are different change management models, and I just listed 4 of them there. ADCAR is a very common one. And for those of you who've taken the classes, and if you're taking the boards, these were on there. I do remember, so study those and know the differences, things like that. Okay, so we use this as a kind of curve because it was medically appropriate. And so you go, those are the ADCAR areas, so awareness, desire, knowledge, ability, reinforce. And typically people go through this sort of, like I said, denial, and then frustration, and then despair, and finally acceptance. And this takes a long time. And our last group of hospitals went live October a year ago, and I would say that last group of hospitals, I'm not sure a lot of them are still a lot of the folks are still here. There are some folks that are there. Culturally, that group was the most dug into the old way, and they continue to want to do it the old way. We had a call yesterday where one old way was brought up as that was great, and it actually wasn't, but we didn't argue about that. So that's sort of a typical change and adoption curve that you'll see. So this is an excerpt, both horizontally and vertically, of a timeline that we did, and it doesn't go back to phase 1 and 2. It starts at phase 3, and typically things are broken up by calendar years or fiscal years and phases and things like that. The most important thing on this is that change and adoption started way back here and goes through the whole project. A lot of these other areas don't. So system build and testing and training and all the work that goes into that, and workflow standardization, and even post-go live, some of these things continue to cycle on and off, but that never changes. And I can tell you it still has not changed. So that's the takeaway from this. And just to give you a little bit of an idea, this is actually accurate the way we did. So we went live in the 3 different networks, and the first one we did, and then we waited 9 months before the second one, because the first one's the hardest, and there's a lot more that has to be fixed. And then the second one we did, and there's 5 months between that and here. And I think, in retrospect, we probably need it more than 5 months. Although you would think, by the second or third one, you're humming. We were better, but I still think we needed a little more time. And if you talk to, Todd Gunsberger, who's the CMIO for the Big Providence system, and when they went to Epic and started, they did one and waited a year before the second, and there was a lot of delay. And then they had this team, and they could get a whole group of their hospitals up and running in a much more efficient, quick way. But it takes a while. So this is just to impress you of all of the work that needs to go into change management and all of the different kinds of events, and you need a team of people. So I honestly I started learning more about the practical aspects of this when I was with Cerner, but then being a consultant is a little different than being on on the side where you're living it as well. So I and my team and colleagues, we participated in many of these meetings and discussions that were part of the planning or the actual work that was being done. So, and then this is just an excerpt from a tool that the team used because it's hard to know how ready people are until you ask them. So it's really important to do some assessment and find out where the areas are. So we used heat maps. If you've seen heat maps, they're kind of, you know, the areas of heat are the areas that need attention. And you don't know that until you've kind of assessed that. So, and you all know CPOE. This is an old slide. And actually, I gave a talk last month at the University of British Columbia because a friend of mine who's a physician who now lives in Victoria teaches an undergraduate informatics class there. It's pretty interesting. There's 115 students. And he asked me to come give a talk. So this was part of that. So you all know what CPOE is. You don't look at the definition. They didn't know. So, and I was trying to explain how when you automate clinical processes, how profound things can be. So that is a list of paper orders. And some of us can interpret that, right? But, you know, that's dangerous. So it's just the way it is. So I'm just showing you two sort of standard CPOE orders here, one of which shows the same order in a patient who's allergic. So the next slide talks about decision support. This provides early decision support. And I could still write this order, and I'm going to get another alert. And I can override that alert, and the order can go to pharmacy and nursing. And hopefully someone's going to look and say, this is really serious. You know, he didn't pay attention, and that happens a lot. So the changes are, you know, before and after. Most of you know this. So who changes when you do something like electronic orders or go to electronic documentation? Pretty much everyone. Anyone who writes or executes orders changes. So there's not a lot of people that write orders, doctors, nurses, and a few other people. But the rest of the organization executes orders because care isn't delivered until orders are written. So the recipients of those orders change because the orders are given to them in a different time. It's almost instantaneous. They don't look the same. The transmittal of those orders, they may go to 3 or 4 places. The orders, when they're executed, get billed. That's how the hospital bills for its services. So it's really important. And then orders are faster to execute. You can put real-time decision support in place like I showed you. But if you ask a doctor who used to write paper orders, they're going to tell you this takes longer. And the answer is yes, it does. I would rather have you take an extra 30 seconds, doctor, doing this than scribbling that stuff that you used to do. And the studies back in, you know, that you probably have read or heard about, mostly done in the 1990s and early 2000s, that looked at aspects of CPOE show, you know, they're peer-reviewed. So you can bring peer-reviewed articles to the naysayers. And in our organization, we had very good adoption of CPOE. We are a community. There's only one residency program at Southwest. It's a family medicine. There's 24 residents. So it's not an academic center where the residents are writing orders. These are community docs employed. And we had very good uptake of CPOE. It really was not a challenge other than providing that support. So, and then I think finally I'm going to talk a little bit about clinical workflows. We're doing good on time. So workflow is just a process involving a series of tasks. And I think an experienced informaticist or CMIO are going to tell you, okay, there's system design and there's content, all this. But it's sort of like real estate. It's workflow, workflow, workflow. And no matter what you do you're changing workflows. And to me, a lot of workflow that people perform are things that they've, any of you who've taken care of patients, you have a series of things that you do so you don't forget, no error of omission, and that you do the right thing. And when you impose a change, you pull that workflow rug out from under someone, and you provide them a tool that you think is efficient and lets them do the work, but they have to rethink it from the beginning. And those in our generation have done it for longer, and they don't change as easily. The young hospitalists, when we have a downtime, hate it. They have no idea how to write paper orders. The old docs love it. It's pretty interesting. So you really upset the workflow. So there's a whole lot of workflows. We, I think, defined about between 900 and 1,000, and that's not complete when we did this. At PeaceHealth, the clinical informatics team owns the workflows. I'm going to just show you two that you might think are simple, just to show you the amount of thought that has to go into it. One is outpatient blood product ordering. So I have a patient that I'm following in the clinic, and they have chronic anemia, and they come in and they're not acutely ill, but I need to send them to the infusion center for a unit of packed red blood cells, something like that. So when a physician writes an order, magic happens. I think a lot of what actually happens is completely opaque to most providers. They don't know who gets the order. They don't know all the details of how it happens or what has to happen. But they're not happy if the order is not executed. They're not happy if they don't get the results, which is fair enough, right? So don't worry about the details because they're hard to read. And if you get the slides, you can look at it. This is blood. I've got two of these. This is just ordering. This is the provider seeing the patient and determining that they need a blood. They need a blood product, so they sign the order, and they're done. Here's the magic. So the order goes. Who's going to draw the patient needs some baseline labs. Who's going to draw it? If it goes to the lab, which lab do they go to? If they go to the infusion center, it gets assigned to a nurse. These are both independent workflows here I won't get into. So the patient gets drawn, the blood bank gets the specimen, then the blood bank goes through, and blood banks are very rigid in their process for good reason. So they go through a process of taking the specimen and getting the blood product ready for the patient. When the patient arrives in the infusion center, patient arrives, and then here is the administration process that patient gets registered, which I don't even think I have up here, and then there's an infusion process. And this is just a checklist, basically. It's just shown in a flow diagram where each of these steps has to happen. And if one step doesn't happen, the rest of it falls apart, which for when you implement an integrated electronic health record, those previous steps are the basis for things that ensue. They have to be done. A nurse, for example, can't receive a patient wherever that patient is going to if they don't have orders. I mean, it's just, they can't. So it all has to happen. So I just wanted to give you a sense of the complexity and the detail that has to happen here. So finally, one of the things I wanted to say about this is when we go back to governance and we get requests, one of the things that's determined is, this isn't broken. They're just not following the workflow. You're laughing. So it's a training and workflow issue. We're not going to redesign this. We're not adding that. If you follow these steps, everything will ensue and work well after that. So that's sort of it. So those are the areas I wanted to talk to you about. These I didn't have any particular anything to say, but happy to answer questions or get two different opinions from Dan and I, however y'all want to. Any questions? Yeah.
That was great. Thank you.
Sure.
I wonder if...
So you're on the receiving end of
I'm
this.
on the receiving end. and I did a paper with the Bill's class, I think on physician burnout.
Mm-hmm.
Did a lot of study, and the interesting thing, like the study that, an ER doc does 2,000 clicks in a day.
Right.
What kind of post-go-live analysis are you doing, maybe collecting metadata to look at if docs are, spending pajama time? So,
Yeah.
how many hours are they charting afterwards? How long are each of these steps taking?
Yeah.
And maybe what effects it would have on things like turnover and absenteeism or other measurable outcomes?
So, great question. So, burnout, one of the leading contributors to burnout is electronic health records. That's not the only, but it's one of them. Sometimes it's sort of that, the last straw. So we have and we are and we will. I'll kind of get into that. So we can look at items. There are physician efficiency profiles that run in the background, but for ambulatory physicians only at this point. Epic just released it for inpatient, where you can actually look at what area of the electronic health record they're looking in at the encounter level and then for the day. So they're spending 10% of their time in their in basket and X% of their time here. And then you can also look at the time of day that they're doing it. So what the medical group has done is identifying physicians and other providers who are spending too much time in areas that they shouldn't be. In other words, whatever the reason is, sometimes it's just support retraining, and then also looking at those who have a big blip after, in the evenings. And so that's being addressed. We haven't started that for inpatient, and it's a little bit different because ambulatory encounters are just that. Patient comes in, is seen, a series of things are done, and the encounter is closed. Can't do that for an inpatient because it's not encounter and there's multiple providers, so you can't look at it at an encounter level. Other thing we just did is working with an organization called KLAS, K-L-A-S, on a project that they're looking at they're calling it the ARCH project now, but it's EMR provider efficiency. And they have a survey that about 40 organizations have done now. I think they're going up to 60. We just got the results. So we're looking at those areas where the providers dinged us, if you will, comparing those results to what other organizations are seeing. And Dan, I've talked a little bit about this. I want to bring those data to our executive team as our strategic plan, our big strategic plan has provider and caregiver experience in it. And if we can focus on a couple of areas where providers, in this case the providers are telling us we're not doing well, I want to go there. And it's interesting, there's some areas that we didn't get terribly good ratings, and no one does. You benchmark, you're sort of in the, and then there's other that are really quite distinctive. There's some organizations that do really well in some areas and others that don't. So what I want to do is pick out a few where we're not doing well and we can. And yeah, you want to help with that?
Yeah, sure.
Okay. Yeah, that's interesting. Hi.
I wanted to ask you a question about how you manage or encourage innovation within your system. You know, I certainly recognize that in a big system like this, there are quality things that you're trying to always catch up on, and there are metrics that are established that you want to try to make sure you're doing as well as you can on. But then there's also a how do we try to get ahead of this, and how do we foster new and innovative ideas within our system? And I wonder, you know, from your standpoint, how do you deal with that kind of a strategy?
Not well. And actually, Dan's experience was more mature, coming from a more mature organization. I think that's fair. Maybe, do you think you could address how you did that at UPMC? Because I'll be honest with you, it's a frustrating area because there are areas where we've had providers and other caregivers who have great ideas, and we don't really have a way to take that and support that. Maybe if you would mind.
Sure. So my name's Dan Martich, and I came from the University of Pittsburgh Medical Center, where I was CMIO for 15 plus years. And UPMC is unique in that it is both a health system, it's an insurance product, a group of physicians. There's 3,500 employed docs and 6,000 on medical staff. But we saw the need for innovation, particularly around health IT, a while ago, and we started to encourage that, both of the clinical staff, of the scientific staff associated with the University of Pittsburgh, and in every commercial product we dealt with. So when we bought Cerner, which was in 1998, we said we want a piece of the action. We became the 13th largest stakeholder in Cerner Corporation to help them influence their product line. Judy Faulkner didn't offer the same deal, so we have Cerner inpatient at UPMC presently, and Epic in ambulatory setting. So which led to another opportunity to innovate, and we then bought and investigated interoperability companies back in 04, 05, something like that, and we partnered with, bought a company out of Tel Aviv. It was called DB Motion, if anybody remembers that company. We brought their U.S. headquarters, brought their headquarters to Pittsburgh, innovated with them, and then ultimately sold it to Allscripts about 5 years after we owned it and made a significant amount of money. I'll give Paul Chang credit, who was a radiologist. He developed something called DTS, Dynamic Transfer Syntax, so that you can actually appreciate PACS images better than GE or Fuji or Philips was doing at the time. We developed that in-house. We sold it to Philips for $280 million about a decade ago. And so that has led to something called the Technology Development Center. Now it's been renamed. I've been gone from UPMC for about 3 years. Called UPMC Enterprises, which basically, you saw a Health Catalyst slide up there. UPMC's a heavy investor owner in health enterprises. There's a company called Evolent Health, which is similar to XG in that they do population health understanding, and that's a joint partnership between the advisory board and UPMC. So to answer your question, if you want to do something like that, you better say that you want to do it. You better have the resources and the understanding that if we're going to take great ideas, it goes back actually into that plan, and what happens is it kicks out and says, this is a great idea. It's not going to be solved by the MR, not going to be solved by this vendor product. Maybe we need to do some investigation, and that investigation led to a lot of those either independent projects being funded or partnering with other vendors. I think this, and the market's ripe with those other vendors. I think Amazon and Google and others are probably happy to get into that.
I think we're probably just about out of time. Actually, I was just gonna. Is that the same Paul Chang whose father accused him of destroying radiology rounds because? because because back in our day, when we used to go look at x-rays, our only option was to walk down to the radiology department and put the films up on the view boxes. And then Paul Chang, whose father was a radiologist too, Bob Wachter tells this story. Some of you know Bob Wachter, the author of The Digital Doctor. It's in the book, and I've heard him talk about it, that his father was a radiologist and said, you destroyed, because the physicians on the wards don't need to go down to radiology anymore because they can look at it on that device. Yeah.
Yeah, I actually have one of just discussions I had up at UBC with them was what a PAC system does, and one of the things was it changes the dynamic. Everyone would go down and look at films, and you don't do that anymore. Then there was a social aspect to that that got lost.
Yeah, and you talk to the radiologist.
Yeah.
So.
Yeah.
Anyway, so as we're learning this week in other realms, technology has its drawbacks. Well, I really want to thank Jay for coming and Dan for adding some perspective, and thank you.
Sure, welcome. Thank you.